Hello, everyone. Welcome to the International Postdoctoral Forum, hosted by the Minnesota Center for Philosophy of Science. I'm Sam Fletcher. I am a resident fellow of the Minnesota Center for Philosophy of Science and the host for today's webinar. Our format in the postdoctoral forum is to highlight talks, current research by postdoctoral fellows in philosophy of science across the world, accompanied by a commentary by someone local to the University of Minnesota and a participant in the activities of the Minnesota Center for Philosophy of Science. Today, we're going to have a talk by Dr. Saana Jukola and a commentary by Professor Alan Love. Saana received her PhD at the University of Jyväskylä in Finland, and since then has held postdoctoral fellowships in Johannesburg and then Bielefeld. Now she is a postdoctoral fellow in medical humanities at the University of Bonn, where she's currently working on a project concerning evidence-based medicine. Indeed, most of Saana's work so far has focused on themes concerning objectivity and reliability in science, especially medical research and related fields such as nutrition and pharmacy. So I'm quite pleased to welcome Saana and to hand it over her to her talk.
Okay, thanks, Sam. And thank you all for coming. And I'm going to start with sharing my screen. Yep. Okay, so as you might already here see, there's been a small change in my title of my presentation, namely that now I have this preventive there in quotes, but also only because I'm going to talk about preventive surgery also, but my focus is going to be maybe a bit more on surgery in general. Before I actually go to the presentation in itself, I want to say something about this project. So this surgery project is part of a larger project here at Bonn, namely the critique of evidence-based medicine and the diversification of medical evidence practices. And this is an interdisciplinary group that is working on the project. It's led by Maria Carla Cadepusch-Bondio. Then I'm working as part of it, obviously, and then we also have Kim Friele. And this is a very, very fresh project. We started in October. So what I'm going to say here today is work in progress. And I can already say that the arguments, if you can call them arguments, are going to be quite tentative. And I'm really looking forward to hearing your questions and comments, both on sort of like a detailed issues, but also I would be interested in sort of more general level suggestions about what you would see as maybe valuable questions to ask with respect to surgery. Okay, so the outline of my talk is here. So I'm going to start with talking about evidence-based medicine, principles of evidence-based medicine, and then also previous philosophy of evidence-based medicine. And then I'm going to move to surgery, and I'm going to say something a bit more general about surgery, and then move on to the questions related to evidence practices in surgery. And there I'm going to focus on two issues, namely determining what the sort of so-called characteristic factors of an intervention to be tested in a surgical trial are. And then I'm going to say something about testing the effectiveness of preventive surgery. And then finally, there are some conclusions. Okay, so what is evidence-based medicine in the first place? So it is an approach to doing medicine that started in the 80s, especially in UK and Canada. And the sort of central aspect of it is the idea that clinical decision making should be based on the best possible scientific evidence. And what is best possible scientific evidence is something that I'm going to say. I'll talk a bit more a bit later. So instead of habits or tradition or the personal preferences of the treating clinician, the decision about, for instance, how we should treat a child suffering from headache should be based on existing clinical guidelines, if there are such, or then the existing scientific knowledge. And this, of course, doesn't mean, like, for instance, that the certain characteristics or the preferences of the patient shouldn't have an effect on how they are treated. But for an average patient, the decision about the treatment should come from the best scientific evidence. And then from the medical context, the sort of ideals of evidence-based medicine have been spreading to other fields as well. Here I have evidence-based management, where the question could be that how should a middle-sized IT firm best be managed, for instance. Then there's also evidence-based nursing, evidence-based nutrition, and so on and so on. Okay, so what is the best scientific evidence? A central or core element of evidence-based medicine is this evidence hierarchy, which I bet that many of you are very familiar with, but just in case that not all of you are, I'm just going to explain it briefly. So here in this pyramid, you can see that on top there are these clinical practice guidelines. Then below them, we have meta-analysis and systematic reviews, which bring together evidence from different individual studies. Below them, we have randomized control trials, and then different sorts of observational studies, and then case reports, case series, and finally, the lowest level is animal or laboratory studies. It depends a bit on a hierarchy, or that there are different versions of this pyramid, but it usually, the main idea is that on top we have meta-analysis, systematic reviews, then our randomized control trials, below observational studies, and so on, so on. And what this hierarchy does is that it's supposed to help us in the situations where we might have conflicting evidence from different sorts of studies. For instance, it could be the case that we have observational evidence or evidence from observational studies saying that a drug A works for treating a condition X. But then we might also have randomized control trials that say that no, it doesn't work. And in this sort of cases, when we are making a decision how this condition should be treated, the basic idea would be that we should believe randomized control trials. Of course, not all randomized control trials are better than observational studies, but this is the basic idea that if we have what would be called well-designed, well-conducted randomized control trials, they trump observational evidence, and so on and so on. Here I have this quote from an early paper on evidence-based medicine, that evidence-based medicine de-emphasizes intuition, unsystematic clinical experience, and pathophysiological rationale as sufficient grounds for clinical decision-making. Here it should be noted that since the early days of evidence-based medicine, there's been something that could be maybe called epistemic shift, and then the sort of interpretation of this hierarchy and the idea of how to do evidence-based medicine has become maybe a bit less rigid, in the sense that it is well acknowledged that, for instance, patient value should be taken into consideration, of course, in clinical decision-making, and also that diverse forms of evidence might be included in the process. Still, sometimes you hear these relatively strict interpretation. This is a bit later quote, still not very fresh, still from 2005, that if the study wasn't randomized, we suggest that you stop reading and go to the next article in your search. Note, we can begin to rapidly critically appraise articles by scanning the abstract to determine if the study is randomized. If it isn't, we can bin it. So here's advice for a clinician that would be doing a literature search for finding out how to make decisions in a certain situation. Okay, so what it is that makes randomized controlled trials so special in this context? So here we have this sort of a simple flowchart from Wikipedia about how randomized controlled trial works. The epistemic value that is used for ranking different sorts of studies in this evidence hierarchy is internal validity. Namely that in internally valid trials, it's likely that the outcome of the study is true for those who participated in the study. And how this is supposed to be guaranteed or made possible is via randomization and blinding. So in randomized control trials, when you have the population of patients that is recruited for the trial, let's say that they suffer from depression. They are randomly distributed into different groups, 2 groups or more. And this random distribution into different groups is supposed to make it so that the groups would be on average as similar as possible, so that it wouldn't be the case that one group on average is younger, or that one group exercises more, or one group likes to play extremely violent video games and drink Mountain Dew 7 days a week more often than the other group, or something like this. So the goal here is that the only difference between the groups would be the treatment that they get. So one of the groups gets the drug. If we are doing a drug trial that's supposed to be tested, the other group gets a placebo or an active control, or whatever is used as a comparison. But other than that, they should be receiving as equal treatment or similar treatment as possible. If and when the trial is blinded, it should be the case that no one knows, participants, doctors, researchers, which of the individuals is getting what kind of a treatment. And this is supposed to make sure that there's no placebo effect, or that different sorts of researcher or doctor biases influence the outcomes. And thanks to randomization and blinding, it is thought that then the differences in the outcomes of the studies are all due to exposure. So whether they've got the drug or placebo or active control. And then in this so-called lower level evidence, so for instance, observational studies or case reports, they are more vulnerable to different sorts of biases and confounding. For instance, because baseline differences cannot be ruled out. So it could be the case that the group that is receiving the drug is also this healthier group, or they have some other characteristics that might be actually relevant for the outcomes. Or it could be the case that if the study is not blinded, that the expectations of the involved parties somehow influence the outcomes. Okay. And it seems to be the case that there is certain understanding behind all of this, namely the ideal of procedural ideal of objectivity. Especially this is the case, I think, when we talk about systematic reviews and meta-analysis. But it seems to me that also with respect to how the trials should be conducted, there's this idea that we should be able to restrict, or if it's possible, to somehow completely remove the influence of subjective judgments from the process. And also this is somehow visible in the clinical context, in the sense that the preferences of the treating doctors shouldn't have that big of an effect on how individual patients are treated. Okay, and here is the quote that what is procedural ideal of objectivity from Heather Douglas's 2004 paper, that the idea of objectivity is that regardless of who engages in a process, they would do it in the same way, producing the same results. Like, for instance, sometimes when you look into the research articles concerning meta-analysis or systematic reviews, there's the idea that, okay, that we have a problem if it's the case that different researchers would make different sorts of decisions in how these reviews and meta-analysis are conducted. As I'm going to notice later, then of course Jacob Stekenger has argued that this is not the case, and that meta-analysis do not satisfy this ideal of procedural objectivity. Okay. Philosophy, or that the evidence-based medicine has been a big deal in philosophy of medicine for past 10 years at least, and I'm not going to discuss all of the criticism here. I'm just going to say some of the main lines that there is. Like, first of all, of course, there's this, it has been noticed that even if it would be the case that ideal randomized controlled trials would be internally valid, then real life randomized controlled trials are not. For instance, because usually randomization is only done once, and this doesn't guarantee that the groups would be balanced. In the same way that the blinding can relatively easily be broken in trials, for instance, because the participants get side effects, and because of that, they notice that they are actually in the treatment group. Then, as Nancy Cartwright and others have shown, that even if it would be the case that randomized controlled trials are internally valid, they are not externally valid, meaning that they cannot, or that the outcomes of the studies cannot be extrapolated to other contexts. The typical example from medical research is that until quite recently, the studies have usually been conducted on young men, but still the outcomes of drug trials, or that the same drugs are then used also for women or elderly patients. And then it's a bit questionable that if the outcomes are also valid for these patient groups. Then Barbara Osimani and others have pointed out that unexpected effects may remain undetected in randomized controlled trials, which then means that, for instance, side effects might not become visible in randomized trials only. And because of that, they argue that for this sort of purposes, for instance, for pharmacovigilance, it would be important to allow and include different types of evidence, for instance, observational evidence, or evidence about possible mechanisms. And then I already mentioned, it's been pointed out that conducting clinical research requires different sorts of judgments, often involving different sorts of value-laden ideas. For instance, when you think about how you decide to conduct your randomized control trials. And in that sense, the process is not objective in the procedural sense, and also not in the sort of value-free sense. And all this criticism has then inspired philosophers and clinical researchers to argue that we should be able to incorporate different types of evidence in the processes when we make clinical decision making. Okay, now I'm moving to the surgery part of the talk. And like I said, so this is very new area for me. And in general, that if there's someone out there who is more familiar with this field, then please contact me. I would be very interested in discussing with you. The material that forms the basis of what is now going to follow has come from a review that we did with my colleagues of certain surgical journals. So we looked at how is evidence and evidence-based medicine discussed in surgical journals. And there we tried to find sort of different sorts of challenges and possibilities of conducting evidence-based medicine. I also want to say here that it's quite interesting that there is, at least to my knowledge, very little philosophical work done on surgery. Bennett Holman has a paper published in 2019 where he talks about placebo, where he uses surgery as an example. But other than that, I've only found some very few remarks on papers. And I would also like to be corrected here that if someone knows more material on this sort of philosophical material. I mean, of course, and now by philosophical, I mean philosophy of science or philosophy of medicine. Of course, for instance, in medical ethics, there's plenty of stuff. Okay. Very brief history of surgical research. So before 1850s, surgeries were usually conducted outside hospitals and often as trauma operations. For instance, well, during war cases. And because of that, the surgical knowledge and the surgical evidence that was available were mainly case reports and case series. Then late 19th century, when antisepsis was developed, surgery became possible to also do in hospitals, which meant then that it was possible to operate on more patients and then also conduct a larger scale of case series. And then finally, first surgical randomized control trials were in the 1950s. So in today's surgical research, chronic conditions and treating chronic conditions has become more important. So if during the so-called old days, it was more common that surgeons dealt with different sorts of trauma, and maybe in these conditions, it was maybe easier to see that, okay, if this treatment is actually working. But nowadays, because of the nature of these chronic conditions, for instance, orthopedic surgery, we need better designed studies to see that if these treatments actually work or not. Surgery is still behind some other medical fields when it comes to evidence-based medicine, at least if you measure it by the number of surgical trials. I wasn't able to find any newer data on this. I think that there should be somewhere, but I just couldn't find it now. So this is from 2004, where it was said that in clinical studies in surgical journals, the proportion of randomized control trials is below 10. And not only that, but most of the randomized control trials that are published in surgical journals are not randomized control trials of surgical interventions, but for instance, they assess the effectiveness of a certain drug, for instance, that is used for post-operative care. And so not only that there are few randomized control trials, but also there's a lot of variation in how same procedures are performed in different locations, both within countries and internationally. And also there's a lot of variation in the rates of procedures, how often they are conducted in different countries. Here I took as an example this prophylactic mastectomies for BRCA1 and 2 carriers. So, well, I'm going to say something about this a bit later, but so BRCA1 and 2 is this genetic mutation that makes or increases the risks of getting breast cancer a lot. In a study by Metcalf and others, they found out that almost 50% of BRCA1 and 2 carriers in the US have this surgery, while in Poland the number was 4.5%. Then an old study from the Netherlands found out that 51% of carriers have the surgery, and in France the number was 5%. And there are some studies that show that one of the factors that causes these differences are differences in physician attitudes, which of course in a way goes against this idea of evidence-based medicine, that the attitude of the physician shouldn't be the factor that determines what sort of treatment is being given, but it should be the existing scientific evidence. Okay, I'm just going to say something about the social and institutional reasons for the lack of randomized controlled trials. I'm not going to talk about these in any detail, even though I actually find them quite interesting, and I think that there could be philosophical work done on this, but at least for now, these are not our focus. So the first one is, of course, that authority has traditionally had an important role in surgical education and in practice, so that new surgeons had been trained in close collaboration with older or more senior surgeons who have then taught how to do certain procedures and how to operate. And this is also connected to the idea of surgery as a form of art. There are some articles that say that surgery is like jazz. And then in some of the articles that we found in our review, evidence-based medicine was perceived as a threat to this art of surgery. Then, something I already said, that historically surgeries were usually performed out of necessity, for instance, in situation of war, and well, their effectiveness was easier to observe. Third reason, and this I find quite interesting, is that there is no regulation of new surgical procedures unless they involve novel devices. So, and this is unlike in the case of drugs or pharmaceuticals, of course. So in 1962, FDA required that new drugs have to be proven efficacies inadequate and well-controlled investigations, which then by 1970 was taken to mean randomized controlled trials. And the final reason is that in many of the articles, the authors complained that there's limited commercial funding for surgical trials. And they also talked about financial interests in other ways, which I'm not going to go into now. Maybe if there's interest, we could just talk about that briefly in the Q&A. But the financial interest or the lack of funds were often mentioned here. So next I'm going to say briefly something about some of the methodological challenges of surgical trials that are similar to the ones that we find in pharmaceutical trials. One is small size of the trials. In surgery, it's even sometimes more difficult, apparently, to recruit participants, maybe for understandable reasons, which then means that the trials are underpowered to detect small effects, which is, of course, problematic, especially in the case that if we are conducting that sort of operations that surgery quite often nowadays deals with. For instance, these sort of operations that have something to do with chronic diseases. Then the obvious thing is that blinding is not always possible, at least the blinding of the surgeon. Of course, there have been sham surgeries where, for instance, that they've only made more incision, but haven't actually done anything inside, for instance, the knee. I'm going to say something a bit more about this in a second. But it's still often thought that this is ethically questionable because there's always risk, even if you just make a small hole to the human body. And finally, the external validity question. Namely, surgical trials tend to have strict exclusion and inclusion criteria. And not only with respect to patients, but also the surgeons and the hospitals that are taking part are not necessarily representative of what it would actually be in the clinical setting. And because of the sort of nature of surgical care and treatment, the fact that the hospital setting is not the same might actually have more effect on the outcomes than in some pharmaceutical trials. Okay, now to the sort of two things that I would like to discuss with you later. Because when I was working on this case or these questions, I was trying to figure out that what is there that would make surgery somehow special. That what could be something interesting that we could say of evidence-based surgery that has not yet been said about evidence-based medicine in general. And I came up with these two things that I want to try to sort of test here. So first of all, this thing that determining what the characteristic factors of an intervention are, and then the testing of effectiveness of preventive operations. Okay, so surgical intervention, not like a pill, as author named Slim said in one of their papers in 2005. So what does randomized controlled trial do? Randomized controlled trial tests the effectiveness of the intervention for treating a certain condition by comparing this intervention with the placebo or an active control. And like I mentioned, that it should be the case that the treatment and the control group should receive the same treatment, basically, except for the intervention. And as Holman argues in this placebo paper, then determining what the so-called characteristic factors of the intervention are is very important. Like for instance, that if you test the drug, the chemical composition of the drug would be at least one of the characteristic factors of the intervention. And also standardizing then the intervention would be crucial. So that's basically the intervention would be as similar as possible. And it seems that in surgical interventions, this might be a bit more complicated than in pharmaceutical trials. For instance, that it's been said that evaluating treatment is difficult when developments and variants arise frequently. Look, first of all, there might be no consensus about how certain procedure should be performed. And there are different sorts of variations of how they are being done. This, in a way, connects to the question, or the issue that I mentioned before, that there's no I'm missing the English word. Sorry. Yeah, so that there's no regulation for new surgical procedures. Sometimes it can be difficult to determine what exactly is a new surgical procedure, because it's sort of like that if all surgeons vary how a procedure is being done, like I'm going to talk about a bit later, there's sort of the line between a small adjustment of the previously existing procedure and a new procedure might not be that clear. And then the question is that when should you test this procedure? An historical example of this sort of a situation is the coronary artery bypass grafting. And here is a quote from a researcher who was complaining about the difficulty of the situation, that just when we have accumulated enough data over a sufficient time period, we find that surgical technique has improved or medical therapy changes or both, and conclusions of the trial no longer apply. Okay. Then about the difficulty of standardizing surgical interventions. Well, people obviously are different, and there are also physiological differences. And in that sense, the individualization of the treatment is normal and often required. More is that surgeons also are different. They have their preferred techniques. Maybe they are left-handed or maybe they are right-handed. And they also obviously have their different experience levels. So then the question is that how experienced surgeons should you include in your trial? How does the experience level of the surgeon affect the outcomes of the trial? And how does the experience level of the surgeons included in the trial, what is it? How does it compare with the experience level of the surgeons then actually in the clinical context? And moreover, there's always a learning curve with every new technique. So even if you have a experienced surgeon, they might become better in conducting the procedure during the trial, and they repeat it over and over again. So like Abraham in this paper noticed that surgeons learn, drugs don't. And finally, surgery is multi-professional activity. So groups techniques vary, and what happens before and inside the operation room and afterwards has an effect, or possibly has an effect on the outcomes. So surgical care is a highly technical, complex process and requires coordination of many individuals and systems. And it seems that this might cause problems for the validity of the trials in a different way than we have in the case of pharmaceutical trials. Or somehow, if I try to, like when I was thinking about this, I was just thinking that what is the intervention actually? That it just seems that like the surgeon possibly is part of the intervention, at least the surgeon. I mean, also the other people in the operating room. And somehow I was just trying to figure out this in my mind, that sort of where are the sort of the borders of the intervention that we are testing actually in the trial, to put it very informally. Okay. And this connects, in my mind, maybe to this idea of procedural objectivity, that in these articles where they talked about surgery as jazz or surgery as art, they often emphasize that surgeons improvise and make adjustments to the typical technique, so that it's good surgeon knows how to react differently in different situations, and good surgeon doesn't do the same operation in the same way always. Okay, I put it already. And it seems that this here might be some sort of a tension between the procedural objectivity ideal of evidence-based medicine. Of course, doctors should always be able to improvise, at least to a certain degree, and at least apply the guidelines for the needs of the patients. But it could be the case, like I said, again, this is very tentative. It could be the case that in the case of surgery, it is even more so. Okay. So my final example is this testing the effectiveness of preventive procedures. And here I have as a case the risk-reducing mastectomy, which is used for treating women with BRCA 1 and 2. So women and men also with BRCA 1 and 2 have higher risk of breast and ovarian cancer, and it's very high. So to age 80, for BRCA 1 it's 72%, and for BRCA 2 69%. There are some risk reduction options, for instance, increased or having mammography and MRIs often, or chemo prevention, or the prophylactic mastectomy, which is of course the operation that also, since Angelina Jolie had her operation, I think 2013, has received a lot of publicity, and also the rates of these operations have gone up. So at least on year 2018, there were no randomized controlled trials on this procedure. And maybe for obvious reasons, but I have here a slide about why you don't have them. So, like, first of all, this is about prevention. So BRCA 1 and 2, even though the risk of having cancer when you have this mutation is very high, but it's still not always the case that you would have it. So in that sense, it's prevention, not treatment. At least according to some studies, the few carriers of BRCA are actually willing to participate in randomized studies. Probably because, well, having mastectomy is very radical and also irreversible operation. So in that sense, even if, I mean, we have also pharmaceuticals that are used for preventing different sorts of diseases, but it could be the case that they are less irreversible than this sort of operations. So there's obvious ethical issue, but also related to this, there's a more like a methodological issue that the omission of decision-making process in a randomized controlled trial could result in lower satisfaction among women undergoing prophylactic mastectomy. So that if women would be randomized in this sort of study, that would immediately have an impact on one of the outcomes that they try to measure there, which would then again have problems for the validity of the trials. Okay. So the existing evidence for this sort of procedures comes from different sources. It is based on pathophysiological rationale, so that reducing breast tissue also means reducing risk of cancer. There's observational studies that show that there's associated with more than 90% decreased risk of breast cancer for carriers of these genes. And also modeling approaches suggest that this approach works. But these are all so-called low-level or lower-level evidence from the pyramid that we had. So here, I guess one could argue that this is a case where we have evidence from different sorts of sources. And if it's the case that they support this, we could say that conducting these operations, especially because the risks are so high, is acceptable. And here I have a slide, very not well formulated thought, but still I thought that at least in this case that the development of this sort of genetic testing has been challenging for the EBM principles, because it's creating some sort of pressure to develop methodologies for testing these preventive measures. And it could be the case in surgery. This is more problematic than in some other fields of medicine. Okay, I come to the conclusions. Well, surgical research obviously has a lot of interesting ethical questions, but it also seems that there's a lot of interesting epistemological or social epistemological questions that could be addressed. But still, there hasn't been lots of philosophy of medicine done on that topic. And it also seems to be the case that there's some sort of tensions between the ideals of evidence-based medicine and the requirements of surgical practice. And here I discussed these two issues, namely that the surgical intervention is not like a pill. And also that in this sort of a case, as in the preventive surgeries, some of the ethical limitations of surgical randomized controlled trials also cause considerable epistemological issues. Yeah, and I conclude. Thank you.
Thank you very much, Saana. That was a wonderful talk. I learned a lot from it. Next, Alan Love is going to be giving a commentary on Saana's presentation. Alan, go ahead.
Thank you, Sam, and thank you, Saana, for the really stimulating presentation. I think there is a lot of material here, and it'll be interesting to see how you develop different aspects of it. My comments today are combined from myself and Stephen Stovitz, who is a medical practitioner here at the University of Minnesota. The two of us have taught philosophy of medicine together in the past and have collaborated on some writing projects. I had wanted him to be able to be here today, but he could not. So instead, it will just be me, but some of the ideas that you'll hear are from him as well. So we just have 6 short responses and questions with the idea that we'll move into discussion, and Saana can respond as she wants to, and also our audience can ask questions of a different kind. These 6 different questions or issues: what exactly is evidence-based medicine? Significant effects or triangulation on causes? RCTs, where the problem really lies, accounting for time in surgical RCTs, defining control groups, and adverse side effects or expected effects. And basically, we've organized these in such a way that they kind of move from more general issues to more specific issues related to surgery, although that's clearly predominant throughout. So the first is, what exactly is evidence-based medicine? I think that it's clear that it's got a kind of slogan and a label, but it also contains certain kinds of diversity. As Saana highlighted, early on, it was about de-emphasizing intuition, unsystematic clinical experience, and pathophysiological rationale. But as it has been articulated over time, we get more of a sort of synthetic perspective that seems to suggest that it is not about throwing everything except RCTs out the window, and includes bringing together judgment from clinicians. And so it seems like constraining subjective judgments as a part of EBM is not the same thing as saying that something is mechanically implementable, and limiting the influence of researchers' idiosyncrasies on evidence synthesis is not the same as a procedural ideal of objectivity, something like they would do it in the same way, producing the same result. Now, I know that Saana has thoughts about this because she's written in other places on the procedural ideal of objectivity. And so I invite her to say more about that if she would like to, but it seems quite important to keep in view. Additionally, I think it's now been long enough that we need to think about evidence-based medicine as having a history, and recognize that the things Saana highlighted about changes over time are actually quite relevant for understanding what it is. And so I think increasingly work on the historical development of EBM is pretty important. Second issue, significant effects or triangulation on causes. So what exactly is the aim of evidential synthesis? Is it robustly supporting a particular significant effect from a treatment? That's the way it's oftentimes phrased. Or does it include the triangulation on causes, whereby different kinds of evidence robustly support a conclusion? And I highlight this because in recent discussions of replicability in the sciences, there has been talk of bringing in issues of triangulation to increase the robustness of particular claims. And of course, in the context of EBM and surgery in particular, right, it'd be interesting to explore to what degree EBM can accommodate inferential strategies of this kind. And it seems like this really does touch on that last point Saana made about genetic testing, because the sorts of reasoning that go into genetic testing are going to be coming from different lines of evidence, and certainly not all from RCTs. And so there's going to be a question about exactly how the evidential synthesis occurs. And that might be quite pertinent in the case of surgery, because that synthesis might look different than the standard meta-analyses that EBM is focused on. And that, I think, brings us to just recognize that, as Saana nicely showed, there are a variety of problems with RCTs, and that in fact, many times when people complain about EBM, they're actually complaining about RCTs. But of course, you can complain about RCTs independently of EBM. There are a variety of epistemic and ethical issues, again, things that Saana already touched on, so I won't say that much more about them, but I think it is important to talk about where the criticism should be lodged. Should it be lodged at evidence-based medicine, or should it be lodged at RCTs? And I think that changes the dialectic about how EBM should respond to certain kinds of criticisms that we might level against this experimental methodology. This is just a humorous thing I think is important to highlight. Some of you may be familiar with this paper. It was a way of poking fun at the way in which we do make well-supported decisions without RCTs. The joke was that when people jumped from the plane to test the RCTs, no harm came to them because they were close to the ground. But of course, we don't do RCTs for parachute use, and yet are quite confident for them being a interventional strategy when jumping from airplanes. And so maybe there's some parallels here for the case of surgery. Fourth, accounting for time in surgical RCTs. This is where we get a little bit more specific. With the exception of acute traumatic injuries, there's often a time component in surgical RCTs along the following lines. Imagine you're in orthopedic surgery and you've got some situation like, say, a ACL tear, and someone has knee pain for 6 months and then goes to see a surgeon. They're then randomized to surgery versus non-surgery if you're setting up the clinical, the RCT. But even if surgery is seen as more successful, there's no accounting for the people for whom non-surgery in the first 6 months provided a benefit, right? So we've got this question of the timing of when somebody is actually coming and being enrolled in the trial, and the various processes that may or may not have occurred in the interim. And that's oftentimes the case because surgical RCTs, apart from the traumatic injuries, happen when something doesn't go away. Or won't sort of be healed in the way of just letting it develop over time. So that seems especially relevant for preventative surgery, because part of what you oftentimes are doing is waiting. And so then there's a question about, well, do you do something in advance or do you wait? Fifth, defining control groups. How should we approach control groups in surgical RCTs? Must the control group include a sham surgery, which is one thing that people sometimes advocate for as the proper control treatment? Or is it enough that the control group merely has an equal expectation of success? And so the sham surgery might not actually be essential for setting up the RCT in the first place. And of course, key question, how would you decide which is most appropriate? And all of the variation that Saana highlighted for us is going to complicate matters. And also particularly with respect to standardization of those procedures across different operating scenarios. Finally, adverse side effects or expected effects. How do we distinguish between side effects, adverse events, and expected effects in RCTs? So for a pharmaceutical RCT, if someone took a pill daily and that pill forced them to require anesthesia leading to nausea, miss 5 days of work and have a scar, all of those would be considered side effects or adverse events. For a surgical RCT, all of these are expected or normal. So on what basis do we distinguish between them and thereby use different detected effects in the context of EBM decision-making? Again, this seems especially relevant for preventative surgery because it's all about sort of expected trajectories that you are following. So with that, I will stop, say thank you to Saana for a stimulating presentation, and I look forward to audience questions and further discussion.
Thanks so much, Alan. Before we go to Saana for responses that she has to Alan's commentary, I just wanted to give everybody a little bit of information about our Q&A procedure. You'll have two different methods for asking a question during the Q&A period after Saana gives her response to Alan's commentary. One option is to put your questions into the chat. If you do that, then when they come up in the queue, I'll be able to ask them to Saana on your behalf directly. So if you want to use that method, you can put them in the chat. Another option will be to use the raise hand function. You should be able to access that as well. If you do, you'll be put in a queue that I can access. And when it's your turn in the queue, I'll be able to unmute your microphone so that you'll be able to ask your question directly to Saana. Although my understanding is that it will just be your microphone that will be unmuted. Okay, great. So while people are thinking about their questions that they might want to ask, let's go to Saana to see what responses she has to Alan's commentary.
Okay, yes. Yeah, thank you, Alan. Very good comments. And I'm going to respond just to some of them. Yeah, so first of all, yes, so the historical development of EBM is actually something that I think the historians in our group are going to work on at some point. And also it was sort of planned that I would also do at some point just to see that how and whether and if so, how the ways of discussing evidence-based medicine have changed in surgical journals. So I agree that this is important both for philosophical and then for obviously historical reasons. Then the points about where the problem lies, whether it's randomized control trials or what are we actually talking about when we talk about evidence-based medicine. And then yes, I completely agree that this is something that's that I somehow feel that sometimes philosophers could maybe pay a bit more attention to, or work in collaboration with, for instance, sociologists. Because in medical evidence production, given the nature of the field, these different sorts of institutional and methodological and obviously ethical questions are often intertwined. And then of course, then there are different sorts of political issues at play also. And then if you only focus on, for instance, the methodological aspects of randomized controlled trials without discussing the institutional structure of how drugs are regulated, I would say that the analysis easily becomes somehow limited, or especially in the case that if you don't want to talk about ethical issues in your analysis. So that it's sort of like that we would need to have that sort of accounts that take into consideration these different aspects of research. Yeah, and then I want to say something about accounting for time. Yes, the fact that surgery for many is maybe the final option after you've already tried all kinds of things is obviously very relevant when we think about how these studies should be conducted. And it also seems that this would be a problem for, or it would easily be maybe a problem for observational studies, because maybe it would be the case that those who end up in surgery have already somehow more serious case of whatever they are suffering from than there. Yeah, I now choose not to go into the procedural ideal of objectivity and meta-analysis stuff here, because just to save time and maybe to give some time for other people to discuss also.
Great. Thank you, Saana. So I have a first question from Yoshi. Yoshi, I've now allowed you to unmute your microphone. So if you do so, you should be able to ask your question to Saana.
Okay, can you hear me? Good. Thank you so much for the interesting talk. So I have one question. You you explained some problems peculiar to surgical research or maybe preventive surgery in the context of EBM. And from my non-expert perspective, one potential response to these problems might be something like, well, the spirit of EBM is important, but how it is operationalized must be different depending on the context, and the existing way of operationalizing EBM is focused too much on like pharmaceutical studies. So we need some different way of operationalizing EBM. So my question is whether there had been such discussion, maybe among medical practitioners, and also whether or not there has been such a discussion, what you think about this potential way of responding these problems.
Yeah, thank you for the question. Yeah, I think that you are correct, and this probably would be a reasonable answer to this sort of questions. And actually, it seems that, and this, I know that in this presentation, I didn't go into these details, but for instance, in quite many surgical articles, when they first identified these problems with typical randomized control trials, for instance, that you can blind or the surgeons learn and so on, they have suggested different sorts of methodological solutions for these problems. And why I'm looking at further away is that because on my wall, I have a whiteboard where I've written these things down, but because I don't have my glasses, I can't see that far. But so in the surgical journals, people, or surgical articles, they have sort of suggested for different ways of trying to conduct trials that would somehow go around these problems that typical randomized control trials have. And for instance, one of the things that they say that, okay, that we could have basically this type of like combining different sorts of evidence, that we have observational studies. Nowadays, we can also have these big amounts of data that also enables this sort of more long-term perspective in following how the patients in certain trials are doing, and so on, so on. So yes, there definitely been these sort of suggestions for how to operationalize EBM in this context.
Okay,
Our next,
so
sorry, go ahead, Yoshi.
Yeah, just quickly. So you, it sounds like you're more or less, what can I say? You think that's a right way to go?
So like I said, I've been reading this stuff about surgery for 2 months, and I feel that I'm not ready to say that what I feel would be the right way to go in this context. I mean, just sort of, I don't know enough about surgery
Okay.
to come, sort of like take a strong stance here.
Thank you.
Our next question comes in the chat from Heather Douglas. So Heather writes, the evidence that preventative mastectomies seems strong. I guess that their effective seems strong given the reduction of death rates. Given this, wouldn't an RCT be unethical as well as unlikely to successfully recruit participants? This is not only the case, parachutes aside, when medical preventative interventions are so clearly successful based on cohort studies that RCTs would be ethically problematic. RCTs for pap smears, for example, were not done because of the massive reduction in mortality they produced. This is more about the preventative aspect of the intervention than the surgical aspect.
Yep, yeah, that's true. That it seems that in this case, and because at least the sort of numbers that I've seen for other measures, if I remember correctly, it was the case that regular MRIs, the reduction was about 50%. And in this case, it would be that there's a clear difference. And it would seem that we don't have equipoise, and then it would be problematic to do a randomized control trial here. Maybe the situation would be different than if there would be a new prevention that would be maybe less invasive but still showed good results. Then maybe randomized control trial would be ethically less problematic, but at least under these conditions that we have now, it would seem a bit of a, well, ethically a problem to try to do that for just for the sake of scientific knowledge.
Our next question comes from Alan again.
Yeah, so Saana, I wanted to come back to something that you discussed in talking about the surgical intervention not being like a pill. And there you were highlighting that when you're thinking about the intervention, Holman's 2019 paper highlights that you want to determine the characteristic factors of the intervention in order to really sort of be confident that you've set up your treatment and control group in the appropriate contrasting way. However, as you know, there are some controversies in surgical practice that would not necessarily seem to be characteristic factors of the intervention. And I'm here thinking of the bouffant caps versus skull caps controversy, which maybe you could say a little bit about that, and then how to understand something like that in the context of determining characteristic factors.
Okay, so for those of you who don't know about this surgical cap debate, this is something that took place, I think it was a few years ago, concerning what kind of headwear people should wear in operation rooms. And there are two sort of different type of things. There's the surgical cap, which is that sort of a thing that you often see in well, TV shows about hospitals. And then there's this, I'm not quite sure how to pronounce it, bouffant cap, which more looks like this sort of a shower hat type of a thing that sort of covers all of your hair, or you can just put all of your hair in there. And there was a debate about that which of these would be better for reducing the risk of infections in the operating room. And there was all kinds of things involved in that. There was also in the debate, so it was mainly between surgeons and then the operation room nurses. Nurses said that this bigger bouffant hat is more hygienic. Surgeons said that the surgical cap is as good. And then the question was that if there is evidence for these claims. The argument for the bouffant cap was mainly based on sort of idea that if you don't cover all of your hair, there's going to be stuff falling out of your hair, and then it's unhygienic. The surgical side of the debate said that there is actually no sort of better level evidence that would say that this is the case. they also argued that being a surgeon, part of being a surgeon is to wear this sort of a certain type of a hat, which nicely demonstrates this sort of, how to put it, sort of the importance that wearing certain type of clothes and the habitus of the profession can also have in this context. Then this debate sort of spread, and then there was, for instance, an article called Naked Surgeons, where they discuss that whether then the point of the article is basically that actually if you just look at the evidence, then surgeries should be performed naked because that's most hygienic, because apparently especially men, if they wear scrubs, they shed more bacteria than without them. But in the article, as they pointed out, well, we don't usually do this like that because evidence is not the only thing that matters. Also, for instance, maybe aesthetics and practical issues should have part in the decision making too. So this is a funny case about sort of that how evidence and different sorts of factors affect how we decide how to operate in clinical context. And now I noticed that I've sort of missed actually what you, Alan, asked me.
So I was thinking about that particular controversy along the lines of this point that you brought up about Holman's work on characterizing the factors.
Yeah. So maybe, I mean, at least if we would think that, because I guess that the sort of hygiene in the operation room also has an effect on how you on the outcomes of the certain procedure. Well, and in that sense, the sort of these sort of discussions about the clothing and operation room would also be relevant for that. I know this is now not a very good answer to this question. I apologize.
No, that's helpful. I mean, it's I think part of the complex space that.
Yeah.
I had a follow-up, or maybe it's a loose follow-up to Alan's question. One of the things that I found most interesting about among the different information that you provided in your talk, Saana, was pointing out that a big difference between, say, prescription drug trials using RCTs and potential surgery RCTs is that there's much more precise control over what a pharmaceutical intervention is supposed to be, whereas there's a lot more diversity in surgical intervention, even to the extent that these surgeons talk about the diversity in terms of art or music or performance. I think there's something probably right about what they say in terms of the local decision making that they have to make. But at the same time, I think that I guess I had the thought that there's maybe one way of looking at the situation that sees these as differences in degree rather than differences in kind. That is to say that, technically speaking, the pharmaceutical interventions themselves have some diversity within them. Small differences in the amount of drug administered, when they're administered, the circumstances under which they are administered. And it just so happens, though, that those differences are, and that variability is sufficiently well controlled or measured, or at least estimated in pharmaceutical RCTs, that we can nonetheless, at the end of the trial, perform calculations, say, about the average effect of the intervention. The idea here is something like the intervention that actually gets implemented is selected from some probability distribution of precise interventions. And in the case of pharmaceuticals, that probability distribution is fairly narrowly distributed, and we know what the relevant characteristic factors are. Where in surgery, maybe the distribution is wider and the characteristic factors are different. But I wonder if in principle, at least, the same sorts of strategies for determining the effectiveness of surgery could be applied from that viewpoint. I was just curious about whether or not you thought that that there's something right about that, or there are additional complications that I may not be attentive to.
Yeah, thanks. Honestly, I'm not quite sure yet. Because this is something that I sort of wanted to try out with you all, because it was somehow my gut feeling that there might be not only a difference of degree somehow, but there might be something also qualitatively different. But honestly, I'm not quite sure how it is. I mean, this sort of because of course they try to standardize the procedures to a certain degree. And sometimes, for instance, that if you can use what is it called, the robot surgeons. I don't remember the name of this device, but so for instance, that at least in that sense, it would be as standardized as possible. But still, yeah, so I mean, I can't answer your question. I mean, I could maybe try to come up with some sort of answer, but I don't feel that it would be an honest answer in the sense. So yes, I'm not quite sure that if it's just a matter of degree or also somehow if it's qualitatively different.
Maybe one circumstance in which differences in degree become large enough that they become qualitative differences in this circumstance might be a situation where there are so many characteristic factors and so much variability that it's quite unreasonable to expect that any sample of interventions that one might implement is a representative sample from the real distribution of interventions. I think the role of the things like the robot surgeons and standardization in pharmacy and so on, they don't so much eliminate variability, but they highly constrain it so that the actual distribution of interventions implemented is representative of the ones that would be implemented if a procedure or a drug were approved. So I might see like a qualitative difference arising if there's so little control over, I guess in Holman's terms, the characteristic factors, and so little known about them that we have no way of estimating or determining whether or not the distribution of interventions made in a potential surgical trial are actually representative of the ones that would be implemented. Great. I think this actually brings us to the end of our time together today. And indeed, we've actually come to the end of the questions in the queue as well. So thank you, Saana, so much for your very stimulating talk. And thank you, Alan, for providing your comments. And thanks as well to all of the attendees for coming to listen and asking your questions. I hope that you all have a restful weekend wherever you're tuning in from. And we hope to see you at another Minnesota Center for Philosophy of Science event soon.
Yeah, thank you.